Good afternoon, dear colleagues. I'm Dr. Michael Wong from Hong Kong. It's my pleasure to share with you my experience on the pulmonary hypertension and ASD. So for the coming 15 minutes, I will try to share some illustrative case to discuss the difference in clinical presentation, difference in severity of the pulmonary hypertension, and also the different treatment and outcomes of different cases. So let's start with the first case. This is an elderly gentleman just following the last lecture. Actually, initially presented to the emergency department because of acute retention of urine. Routine admission assessment show atrial fibrillation, and also clinically there is bilateral low limb edema. And following assessment showing the echocardiogram, you can see the dilated right ventricle and also right atrium. And also on a closer view on the short axis, there is a communication between the LA and RA. So there is a presence of ASD, and the pulmonary pressure is elevated with the RVSP up to around 15 millimeter mercury. And the presence of ASD is subsequently confirmed by transesophageal echo. And because of the advanced age, atrial fibrillation, we want to rule out other concomitant left side heart disease. So the coronary angiogram was normal, cardiac catheterization, although there is systemic hypertension, but the left side filling pressure is still within the acceptable limit. Pulmonary pressure is elevated with a mean of 27 millimeter mercury. Still left to right shunt with QP/QS 3.1 and elevated QP of 7.8 liter per minute. However, the PVR is still quite relatively normal, 1.78 Woods unit only. Therefore, we decided to proceed for percutaneous ASD closure. And you can see the pre and post. After the occluder implantation, there is no residual shunt, and the right heart significantly shrunken, and also the RVSP also shows some improvement. So I think this case, following our last lecture, also shows that ASD can present in a relatively advanced age as the first presentation, and also it can present as an atrial arrhythmia with atrial fibrillation, especially after a middle age of presentation. Also, elevated pulmonary pressure in ASD can be driven only by the high pulmonary blood flow rather than the pulmonary vascular remodeling. So the degree of pulmonary hypertension actually even presented in the elderly age is not necessarily very severe in this age group. So let's look at the second case, which is on the contrary, is a relatively young gentleman, 24 years old, referred from the private sector to our center for suspected pulmonary arterial hypertension with right heart dysfunction. The patient was initially born in Canada and back to Hong Kong 1 year before the presentation, and initially seen doctor just for some febrile illness and take the chest X-ray for the assessment of the febrile illness, but found to be abnormal and therefore had subsequent investigations. Clinically, the patient is relatively asymptomatic with normal developmental stage, although the patient reported not to be very active in terms of exercise. Private transthoracic echocardiogram shows normal LV but dilated RV with impaired systolic function with no obvious septal defects. He also had other imaging, including CT coronary angiogram and also MRI heart performed, which showed no coronary artery disease, and also MRI heart showed dilated right ventricle with impaired systolic function, but no other structural abnormality mentioned. So upon first attendance, we do the usual physical examination, which was quite unremarkable, except we found the patient had a fixed split second heart sound and also systolic murmur over the pulmonary area. And echocardiogram, again showing the dilated right ventricle, and also over the short axis view, there is no obvious Doppler flow across the secundum ASD area. However, also the RVSP seems to be elevated, and also RV is significantly dilated. But because of the physical finding, we try to pay more attention during the transthoracic echo. We know that sometimes it's not easy, but actually during some off-axis tilting of the short axis view, we found there is actually a communication between the LA and RA. And also on the apical off-axis view, with some tilting, also we can demonstrate, even on the transthoracic echo, we can demonstrate the communication between the LA and RA. Therefore, because of the transthoracic echo finding, we try to look back the initial CT and MRI report from the private. Actually, we found that there is a presence of sinus venosus over the SVC region together with the partial abnormal pulmonary venous drainage over the right upper pulmonary wing. Therefore, we initially planned to have a TEE and right heart cath in our center, but the patient subsequently had a surgical operation in private sector. And afterwards, things much improved. You can see the D-shaped septum has largely gone. The right heart is improved, and also the pulmonary pressure normalized afterwards. So in this case, it highlights ASD actually can present at any age. Also, incidental finding with abnormal chest X-ray can be the mode of presentation. And physical examination actually is very useful. And always remember other less common type of ASD, such as the sinus venosus and unroofed coronary sinus during the workup of pulmonary hypertension. So let us look at the third case, which is a middle-aged lady who had no murmur since adolescence, and subsequently had a fenestrated ASD closure in private sector around 15 years ago, and later on back to our hospital for follow-up around 6 to 7 years ago. And after our echo assessment, actually after the fenestrated ASD closure, you can see the RV is still dilated with D-shaped septum. Also, the pulmonary pressure is still on the high side. RA area is mildly enlarged. So you can see because of the fenestrated ASD closure, there is still a communication, but it's a small jet between the LA and RA with a predominant left to right shunt. And we treat this case just like residual pulmonary hypertension with sequential up titration of the PAH medication. The patient was on sildenafil all along, subsequently add on ERA, and later on add on selexipag around 2-3 years ago. And we've closely followed up the patient with almost annual assessment. Actually, this year, the patient is still doing quite well with functional class 2, 6 milliwatt more than 400 meter. And also, you can see NT-proBNP is in the intermediate zone is not very low, but is still acceptable. So this case highlights in selected case, fenestrated ASD occluder can still be used just to give it a safety mechanism in case there is a RV dysfunction or RV failure. In case of residual PAH, the fenestration will keep it patent and also continue on the pharmacotherapy, just like other patients with PAH. Another case, which is 31 years old lady who was a domestic helper from Philippines, working in Hong Kong for more than 10 years, referred to our center 3 years ago because of also abnormal finding on chest X-ray. She was asymptomatic all along and still managing domestic work, but on room air, the patient already desaturating, but functionally 6 milliwatt you can see is more than 500 meter. We performed first right heart cath assessment, already showed there is a significant elevated PA pressure, mean of 76, and also clearly right to left shunt predominantly with a QPQS less than 1. Therefore, the patient was initially started on sildenafil and later on ERA. On the latest echo, you can see the RV is still dilated, D-shaped septum, but the function is still relatively maintained. Also, still a very clear large ASD with bidirectional shunt. So on further functional assessment, actually the free wall longitudinal strain is relatively maintained at negative 16%. Bidirectional shunt, RSP of course is very high. RAS pi is more than 10, TAPC is more than 1.6. RA and systolic area is still less than 20, and also preserves systemic cardiac output. So overall, functionally, the patient is also doing okay with 6 milliwatt, more than 500, and also NT-proBNP downtrend after medical treatment. So this case also highlights the incidental finding of abnormal chest X-ray can be, again, the mode of presentation. And Eisenmenger syndrome, of course, is a contraindication for subsequent ASD closure, and the treatment would be the same as those patients with other group 1 pulmonary arterial hypertension. So another case of Eisenmenger syndrome diagnosed at the age of 34 years old, also initially presented with incidental finding during a road traffic accident 10 years ago. So the initial chest X-ray in the trauma room, you can see very dilated pulmonary trunk with pruning, and also CT showing very dilated pulmonary trunk. Initially, the patient was started on sildenafil, but subsequently the patient defaulted follow-up since 2014 and presented again for headache. And with this kind of CT imaging, and found to have a brain abscess in 2020. The patient was subsequently, after the treatment for the brain abscess, has subsequent regular follow-up and resumed on the sildenafil monotherapy. And of course, you can see the chest X-ray after a few years, the pulmonary trunk is even more prominent with a very significant pruning. But up till now, the patient is still on sildenafil monotherapy alone with a relatively preserved functional status, 6 min walk more than 450 meter, New York Class 2, and also anti-proBNP less than 300 picogram per mil. You can see from the echocardiogram, although the RV is dilated, but functionally is still doing okay. ASD is still present, pulmonary pressure is very high, RVSP more than 80. However, functionally, the RV is still doing okay with RVS pi more than 10, TAP-C more than 1.6, free wall longitudinal strain negative 23%, and also the RA and systolic area is also relatively preserved. So in this case, we highlight brain abscess can also be a potential complication among patients with ASD, pulmonary hypertension, especially Eisenmenger syndrome. And for patients with ASD, pulmonary hypertension or Eisenmenger can be stable for many years in some cases. But not, but not every cases are so lucky. So this is another case of a young lady, 31 years old, presented 15 years ago with SOB at the adolescent age. At that time already New York Heart Class 3. Echocardiogram initially showed grossly dilated right heart with no obvious ASD noted, dilated pulmonary trunk, and also RVSP already 77 millimeter mercury. However, subsequent imaging follow-up showing actually there is a communication between the coronary sinus and also the LA. So subsequently, the patient was diagnosed to have relatively uncommon unroofed coronary sinus type of ASD, and therefore had undergone fenestrated coronary sinus closure for this unroofed coronary sinus type of ASD. Initially, the pulmonary arterial pressure actually came down to a mean of 26 millimeter mercury after the operation. But unfortunately, after 1 to 2 years, the pulmonary hypertension bounced back with pulmonary pressure up to around 60% of the systemic blood pressure. And therefore, atrial septostomy was performed a few years later as a bridge to lung transplantation. And the patient was on list for lung transplant since 2015. And you can see from the echocardiogram the stenting for the atrial septostomy here, and also dilated RV, and also D-shaped septum. RVSP is still very high. Fortunately, after 6 to 7 years of waiting, the patient successfully undergone lung transplantation with the pulmonary trunk. You can see much improved afterwards, and also cardiomegaly improved. And from the echocardiogram, you can see actually the dilated right ventricle has significantly improved, and the function is still maintained. So in this case, highlight the shortness of breath at young age can be a common mode of presentation, and also we need to pay attention of uncommon ASD type in patients presented with pulmonary hypertension of unknown etiology, and multimodality imaging can be useful. Also, residual or recurrent PAH can occur after ASD closure, and in case refractory to medical therapy in the recurrent pulmonary arterial hypertension, finally, lung transplantation can be as a definitive treatment. So at the last case, this is a more complex ASD situation, which is a lady who is in the middle age, presented with shortness of breath, with a very significant enlarged heart on the chest X-ray. Echocardiogram show also a significant mitral regurgitation, dilated right ventricle, D-shaped septum, presence of a secundum type of ASD with predominant left to right shunt. RVSP is very high, almost more than 90 millimeter mercury, and also significant tricuspid regurgitation and dilated right heart. We carefully evaluate the patient and perform cardiac catheterization, which, besides the significant elevated PA pressure, also found to have a significant elevated left side filling pressure with a LA of 22 millimeter mercury. Also, significant left to right shunt with QP 8.7 liter per minute. Also, very low systemic cardiac index, only around 1.6 liter per minute per meter square. While the PVR is still relatively maintained less than 3, only 2.6 Woods unit. And because of all the findings, we decided to proceed for the ASD closure plus valvular surgery, and post-op the cardiac size significantly improved. Actually, the dilated RV significantly improved. Also, the MRTL was reduced to mild degree, and also the RVSP significantly reduced to less than 30 millimeter mercury. So this case highlights the ASD when also having concomitant mitral regurgitation because of the hemodynamic physiology would increase the left to right shunt ratio and also reduce systemic cardiac output. And the pulmonary hypertension in this type of complex situation can be multiple. It can be due to left heart disease, elevated left side filling pressure. It can be due to the high pulmonary blood flow with more than 8 liters per minute of pulmonary blood flow, and also long-term pulmonary vascular remodeling. And correction of the structural abnormality in this case actually relieve the elevated left side filling pressure, especially with the MR, and also reduce the effect of pulmonary blood flow on the pulmonary pressure, and therefore help the patient. So, ladies and gentlemen, in conclusion, patients with ASD and pulmonary hypertension can present with a wide range of clinical presentation at any age with different severity, and also even present with initial finding of atrial arrhythmia. Lateral history largely vary, ranging from mild stable symptom, Eisenmenger syndrome with some of the case with a relatively stable trajectory over many years, or even right heart failure requiring further interventions. So treatments could be closure, either percutaneous or surgical, complete versus fenestrated, medical therapy, and in refractory case, lung transplantation. So this is the end of my sharing. Thank you very much.